So, in our last couple of explainers, we really got to grips with recognizing and assessing orthostatic intolerance. But that brings us to the big question, right? What do we do next? How do we actually manage this effectively in a busy practice? Well, today we are going to climb what we call the management ladder. It's a really clear, step-by-step approach that takes us from foundational lifestyle changes right up to knowing when to call in a specialist. And just so you know, everything we're about to cover comes directly from the Orthostatic and Medication-Related Dizziness Literature Review, which was put together by Australian Dizziness Clinics specifically for clinicians like you. And this quote right here is the core idea for today. It's a simple, three-rung ladder, lifestyle, a single drug, and then expert input. And the most important part, it really empowers you. Because the vast majority of these patients can be managed and managed well right there in primary care. Okay, here's the plan. We'll look at the ladder itself, then we'll break down each step: lifestyle changes, first-line meds, and referral pathways. We'll also talk about your ongoing role as coordinator, and then we'll wrap up with the key takeaways. So let's dive into this management ladder. The whole strategy is built on this really logical, stepwise approach. It's all about starting with the foundations and only adding more complex treatments if and when they're truly needed. And here are the 3 steps in a nutshell. Step 1 is non-drug measures, and this is for absolutely everyone. Step 2, if that's not cutting it after about 4 to 6 weeks, we think about adding a first-line medication. And then step 3, for those really tricky or resistant cases, that's when we look at getting a specialist involved. Simple, clear, and really effective. All right, let's get started on that all-important first rung, the non-pharmacological or lifestyle measures. And I really want to stress these aren't just polite suggestions. These are powerful, evidence-based treatments that you should be putting in place for every single one of these patients. Okay, let's break this down. First up, we've got to boost their volume. We're talking 2 to 3 liters of fluid and, get this, 6 to 10 grams of salt every single day. That's a lot, but it's crucial for increasing blood volume. Next, we need to physically stop blood from pooling down in the legs. That's where thigh-high compression stockings, the 20 to 30 millimeters of mercury ones, and even an abdominal binder come in. They're a game changer. Then it's all about education. Teach them simple things like rising slowly and those brilliant little counter-maneuvres like crossing their legs or squatting for a moment. It literally helps pump blood back up. We also coach them on what not to do, so avoid those super hot showers, big heavy meals, alcohol, and definitely don't stand still for too long. Finally, we work on building their body's own defenses. Tilting the head of the bed up at night can make a real difference, and getting them started on some graded recumbent exercise, like a stationary bike or a rower, really helps build up that all-important calf muscle pump. Now, this is absolutely critical. This aggressive salt and fluid loading is not for everyone. You have to be extremely careful with patients who have congestive heart failure, severe hypertension, or significant chronic kidney disease. For them, a much safer starting point is a modest fluid increase combined with those compression stockings. So what happens when those lifestyle measures just aren't enough? Let's climb up to the next rung on our ladder. You've given those non-drug strategies a really good go, say for 4 to 6 weeks, but your patient is still symptomatic. This is when we can start to consider medication. This is the key question we face in the clinic, isn't it? When those foundational strategies don't quite get us there, what's the next logical evidence-based move? Well, this is where we add a single agent on top of that existing lifestyle plan. Think of this slide as your practical dosing card. We have 2 main first-line options. First, there's Midodrine. It's an alpha-1 agonist, which means it works by constricting blood vessels. We start low at 2.5 milligrams 3 times a day. Your other option is fludrocortisone. This one's a mineralocorticoid, so it helps the body hold on to salt and water to boost volume. We start that one at just 0.05 milligrams in the morning. Now, the cautions are really important. For both, you have to watch for supine hypertension. That's high blood pressure when they're lying down. And specifically with Midodrine, it can't be taken within 4 hours of bedtime. With fludrocortisone, you need to keep an eye on potassium levels and watch for any signs of edema. And I really cannot stress this enough. Supine hypertension is the single biggest risk we're watching for with any of these medications. It's especially common in neurogenic orthostatic hypotension. You absolutely must check the supine blood pressure at every single review when you're adjusting these drugs. Okay, time for the final step on our ladder. So you've diligently tried the lifestyle measures. You've trialed a first-line agent, but your patient is still struggling. This is our cue to think about a referral. Knowing when to refer and who to refer to is just as important as knowing how to start the treatment. Now, it's good to be aware that there are second-line drugs out there, things like droxidopa or pyridostigmine, but these are really specialist-initiated medications. They're typically started by an autonomic clinic or maybe a vestibular physician, so this is definitely the domain of expert input. And this slide, this is your decision-making cheat sheet. It splits things into two clear camps. On one side, you have the absolute red flags. These are the do not pass go, refer immediately situations. We're talking syncope or someone's actually gotten injured, fainting during exercise, or a scary family history of sudden cardiac death. These need an urgent workup, usually in the ED or with cardiology. Then on the other side, we have our more routine planned referrals. Got a case where you're just not sure, or there seems to be a vestibular component, a vestibular physician is your best bet. If it's neurogenic OH that's just not responding, or you're suspecting POTS, then it's time to get an autonomic clinic or cardiology involved. And of course, for our frail elderly patients on a bunch of meds who keep falling, a geriatrician or a dedicated falls clinic is absolutely the right call. Now here's a really key point. Even when you do refer a patient on, your job is far from over. In fact, you could argue that your role as the central coordinator of their care becomes even more critical. You're the one who keeps all the plates spinning. You're still doing the essential work of reviewing and deprescribing other medications, constantly reinforcing those crucial lifestyle measures, organizing home blood pressure monitoring, and performing those comprehensive falls assessments. You really are the pivotal point of contact and care for that patient. Whew, okay, we've covered a lot of ground today, so let's just pause and pull it all together by summarizing the key clinical takeaways you can use in your practice tomorrow. First, always remember that three-step ladder: lifestyle, then a single drug, then specialist input. Second, our go-to first-line agents are Midodrine and fludrocortisone, and remember, you have to check that supine blood pressure at every single review. And third, know your referral pathways. Go urgently for red flags and routinely to the right specialist for the right problem, whether that's a vestibular physician, an autonomic clinic, or a falls clinic. And with that, we've reached the end of our three-part series. We've gone all the way from recognizing the different syndromes to performing the active stand test, and today, applying this practical management ladder. So the final thought I'll leave you with is this. The very next time a patient walks in presenting with dizziness, how can you immediately use this clear, logical ladder framework to structure your thinking and your management plan right from the get-go? To dig deeper into topics on dizziness, vertigo, and imbalance, and to get your hands on a ton of great resources for both clinicians and patients, please visit us at AustralianDizzinessClinics.com. And hey, if you found this useful, we'd really appreciate it if you'd subscribe and share it with your colleagues. Thanks so much for joining us for this series. We really hope you found it valuable for your day-to-day clinical practice.